Now, what you can see in this illustration of the inguinal canal, I don't know if you can see the little blue ring back there, that represents the deep inguinal ring, and then of course this would be the superficial ring. You can see the relative location or position of that canal to that femoral sheath that we talked about before. They're looking at the femoral artery, the femoral vein. This is sometimes called femoral canal, goes by a variety of names, and it's just filled with lymphatic structures for the most part. But you can see the relative juxtaposition of these two structures. And then the last point that I really want to make, because they're about to, later on, you'll probably learn that this whole system is formed by, I don't know, probably 5 or 6 different ligaments. And each of those ligaments is, in most cases, either a folding, a reflection of one of those aponeuroses, or a point at which they converge. Now, the only one that we will stress here, the only one that I want you to be familiar with, really forms the margin, what's sometimes called the crus. This would be the crus here. The crus of the superficial ring is the external abdominal aponeurosis, and you can see what it does. It just reflects back on itself to form that, at least the superficial component of the canal. The deep canal is much more complex, and I don't know that I even want to get into that discussion.
No.
But in any case, just to come, this is sometimes called the lacunar ligament. This is the lacunar. There's the pectineal ligament down here. But there's another ligament back in here that really contributes to the deep ring. But in any case, all of this interconnection of the aponeuroses forms the iliac. I'm sorry, I keep saying that, the inguinal canal.
When you say
yes,
external layer of muscle that through the aponeurosis makes that layer?
Yes, this particular right here, that's the external abdominal ligament.
External.
Yeah, the external. All right, so our last burden here is to talk a little bit about the abdominal fascia. There's an extensive abdominal fascia that's rather analogous to the pleural membranes of the thoracic cavity, and it's called the peritoneum. The abdominal peritoneum, like the pleural membranes, in many respects, is a single continuous membrane that folds back onto itself at various points. As with the pleural membranes, we will talk about a parietal peritoneum. The parietal peritoneum, for the most part, lines the wall of the abdominal cavity. The visceral peritoneum, on the other hand, is a little more difficult to characterize, but I think you will see that in general, it also surrounds or encapsulates some abdominal structures and totally avoids others. If a viscus, and a viscus is not something that a track athlete throws and meets, a viscus is just any abdominal organ. If a viscus is enshrouded by peritoneum, we call it intraperitoneal. If it's beyond, in our very simplified distinction, if it's beyond, that is to say, external to the peritoneal system, peritoneal membranes, we call it extraperitoneal or retroperitoneal, especially if it's located posterior to the peritoneal envelope. For example, we looked at this before. Actually, you see several components of the abdominal peritoneum here. We looked at this one. Do you remember that? That is the falciform ligament that, remember, is nothing more than an intensified abdominal fold. Remember that anterior abdominal wall just makes that fold. There are going to be fossa on either side, and then it continues. So really what we're looking at in this little tongue that's sticking out at you here, more or less separating the right and left lobes of the liver, is the continuation of the peritoneum onto the anterior abdominal wall. That is the anterior abdominal wall. So we also, also see other components of the peritoneum here. we're going to see that this greater omentum is all peritoneum. It's just all sort of smooshed together there in an interesting fashion we'll talk about in just a moment. And then, of course, there's going to be peritoneum surrounding all of this. So we've talked about parietal, we've talked about visceral. The peritoneal cavity is sometimes a potential space, sometimes a patent space between the two. Technically, it's probably just something you sort of have to memorize because none of this is going to be particularly evident as we continue our discussion. There are no organs in the peritoneal space or the peritoneal cavity. There is, however, fluid, lubricating fluid, as there was in the pleural space, to sort of facilitate transition or one membrane riding over or flowing over the other. Now, we're going to talk more about mesentery later. Mesentery or mesentery, entery implies what, do you think? What do you think of enteric? What do you think of? Yeah, gut, more specifically the intestine. So the mesentery we're going to find is this very complex component or exvagination of the peritoneal system that surrounds the intestines, for example. But the mesenteric membranes don't just stop with the intestines. They actually cover, for example, the colon. They cover a portion of the stomach. They cover a variety of structures, at least partially, even reproductive structures. So, for example, when a membrane begins with MES, mesovarium, for example, we're talking in most cases about a portion of the peritoneum or a comparable connective tissue. Now, we have a better illustration right here. What would you do see, or we have this illustration in just a moment, a little larger. But what you do see, for example, is the parietal peritoneum out here. And you can sort of follow it along. So, for example, inferiorly, as you look at the bladder and the cervix and so on, notice that all of those structures are inferior to the peritoneal membrane. So if you stuck your head in here, you would not be able to see them because there would be those reproductive structures. Genitourinary structures would be inferior to that membrane. And then it continues. That continues on up the wall. All of this is parietal peritoneum. And then what's happening here? It moves in, it invades the interior of the abdominal cavity, surrounds the intestine, and then comes back. So what do we call this double membrane system of the peritoneum? A mesentery. So it's really where the membrane folds back on itself. If the entire room here again is encapsulated in saran wrap and I walk into the room, I'm going to have the saran wrap covering me, and there's going to be two layers back here as I continue walking. Well, they would be the mesentery. And of course, if we're arguing that mesentery encapsulates the intestine, what is running through this mesentery? Blood vessels, lymphatics, autonomic efferents and afferents. So very important in that regard. Now, the other thing you'll pay attention to, we'll talk about some of the complexity of this in just a moment, but there are a number of structures that are not enclosed or encapsulated by the peritoneum. So here we see the same thing in a little higher, a little greater detail. There's a couple things I want you to pay attention to. Again, be able to identify this as the parietal peritoneum. That mesentery, in your personal opinion, based upon your life experience and understanding of the vagaries of the cosmos, would you say the mesentery consists of visceral peritoneum or parietal peritoneum? We know this is parietal, right? This is visceral because it surrounds the organs. Anybody have a strong opinion on this topic? I'll bet Donald Trump does. I heard parietal. Yeah, it would make sense, right? It's not important for our purposes. It's usually visceral. That's usually cast. I would not ask you that on a test because it just seems a trivial question. But I do want you to understand how it's formed, how these mesentery are really just double layers of the. And you can see there's several of these. In fact, look at this thing. That's just craziness. Okay? You have a double layer folded back on a double layer. So here's our liver. What is this? Well, that's the stomach. And so what does the peritoneum do around the stomach? It goes on both sides, reconverges anteriorly, falls down, and this is that thing we were looking at before. It's the greater momentum, then it comes back up to then sort of enshroud the transverse colon. Crazy. How can you explain this? And so the way of the mesentery, the way of the peritoneum is quite convoluted, quite literally. Yeah.
If you look at the intestine that is drawn in the middle with the
This one?
mesentery line, yeah. Is the black line representing
You're saying
this? The black line in the middle, is that representing visceral peritoneum, or is the blue what you're calling visceral?
Well, either way, you're not going to win this because whether that is a single or double membrane, if it encapsulates the viscera, it by definition is visceral peritoneum. I see what you're saying.
So
I wouldn't argue that black line represents anything other than maybe the wall of the intestine. I think I've never heard that, but I've learned to be very diffident in my old age, but I don't think that represents a distinction that you're looking for. And the other thing I want you to pay attention to over here on the left side, and we're talking about some retroperitoneal structures. I have a table coming up, and you can just memorize the table, or you can look at this thing and sort of maybe take a mental snapshot. So here we're looking at parietal peritoneum here. We're down here, way down here at the level of the kidneys here. So are the kidneys encapsulated in the peritoneum? Would you argue? So here's your this blue thing is your peritoneal membrane. So they're not. All right. What about looking at the one above? What about the vena cava? Right there. It's retroperitoneal. What about the aorta? Retroperitoneal. This is the pancreas here. Is the pancreas enshrouded or encapsulated by peritoneum? No. So make sure you recognize those points. By the way, we're going to come back to these three arrows in just a moment. I think I have a better picture for that purpose though. I just thought this was entertaining. This was a famous anatomist description of the peritoneum. The normal abdominal viscera have no fixed shapes and no fixed positions, and every description of them must be qualified by a statement of the conditions existing at the time of observation. Moreover, profound change may be caused not only by mechanical forces, but also by mental influences. So it's a dynamic system, and especially that peritoneum. You saw the fellow following the surgery. Imagine trying to sort out his peritoneal membranes at this point. We'll come back to this. I have a better illustration showing the greater momentum. As you look at the cadaver image here, you can see, for example, this is an outline of the parietal peritoneum, more or less. You can see the liver up there, the stomach, and then the intestinal complex down here that we'll describe in terms of the mesentery. So this is my little table of primarily retroperitoneal structures. So there are some structures that have one side facing the peritoneum. There are other structures, like the liver, for example, that is virtually entirely encapsulated by peritoneum, except for just a small region we call the bare, we call it B-A-R-E, not B-E-A-R, the bare area of the liver. So there's a variety of possibilities here, but in general, in particular, pay attention to this. We'll talk about the GI tract later, but the kidneys are retroperitoneal, the ureter. In fact, you saw that in that anterior wall image we looked at earlier. So as you look at this transection to T10 here, just a few things to pay attention to. Let's focus, let's come anteriorly. We're looking at the lungs here. So what is that black region around the lungs there? What would you call that? Yeah, that would be the pleural membranes in space. Good. And you'll notice that sort of continues here. And of course, we've talked about the recesses and the folds and all of the recesses and reflections. And you can sort of see that here. Now, let's come to the liver. We've already talked about the falciform ligament. We've seen several images of that. But somebody expressed to me what's really happening at the falciform ligament. How would you describe that in terms of the parietal and the visceral peritoneum? For example, whoops, got a little carried away there with my line. Get so excited drawing lines that sometimes it's hard to stop. So, for example, what's 1 and what's 2 there? All right, 1 would be the parietal peritoneum, and 2 would be the visceral. Yep, exactly right. Except that for the peritoneum, it's a little more complicated because this happens at several points. But you're exactly right, and that's what I want you to understand. Not only is the falciform ligament this point at which that abdominal fold adjoins the anterior abdominal wall, but it's also the point at which the peritoneum reflects back on itself, forming the parietal and the visceral components. And we can see, we don't see it very clearly here, but then a portion of the liver then is entirely surrounded by that peritoneum. And you can see the stomach there. We'll come back and talk about that. By the way, a portion of this image is apocryphal. That doesn't exist. That's actually a potential space that is sort of leaving it there, I guess, to facilitate the illustration. Notice the spleen here. There's a little ligament right there. We'll talk about that in just a moment. The gastrosplenic ligament. And as we move south, all the way down to L3 here, our image at once becomes simpler and more complex. In that, what is all the yellow that you see there? Fat. Huh? Well, you said fat, but what is that fat encapsulated within? I think I heard somebody say it. Well, it's peritoneum called mesentery. This is the mesentery. This is the intestinal mesentery. And as you point out, it's a lot of adipose tissue. But what else you see in there? What are those blue and red things?
Veins and
Yeah,
arteries.
blood vessels. So radiating, reticulating, extensively perfusing all of this tissue, extending to all of the intestines you see there are blood vessels and lymphatic vessels and neural innervation, all kinds of things. And we've already talked about the fact that at least formally there are no organs within the peritoneal space. We made a distinction with respect to sensation between the visceral and parietal pleural membranes. Likewise, you should be familiar with the way that the parietal and the visceral peritoneal membranes are innervated. The parietal peritoneum basically shares its neural and vascular supply with the abdominal wall. The parietal peritoneum, therefore, is sensitive to pressure, pain, temperature, and moreover, if the sensation arises from the interior abdominal wall, it's usually relatively localizable. The patient can tell you where the pain is originating and where the pressure is originating. Much less so for the visceral peritoneum. Basically, the visceral peritoneum is contiguous and continuous with the vessel that it encapsulates. There's no tactile, there's no somatic sensation to speak of. And if there is pain, the pain is supplied by visceral afferents. Anybody have a cold shudder when we say that term? What were the visceral afferents? They were autonomic afferents that have somatic neurons. In other words, these are somatic signals that run along autonomic pathways. And in any case, any pain, any sensation is going to be referred to some other location if it arises from the visceral peritoneum. Very, very poorly localized, if at all. So let's talk a little bit about some of these structures.
The surfaces of the organs that lie within the abdominal cavity are also covered with a continuous layer of peritoneum. The visceral layer of peritoneum that covers the organs is continuous with the parietal layer that lines the cavity. The space between adjoining peritoneal surfaces is normally occupied by just a trace of serous fluid. Those organs that lie freely mobile within the abdominal cavity, like the small intestine here, are attached to the wall of the cavity by double sheets of peritoneum, in which their blood vessels run. Complex as well.
And of course, this is the mesentery that we're looking at. You can see the very distinct vascular system where you see the blood vessels at right angles to the intestine there. Those are called vasorectum. And then the interior blood vessels are arcades of it. But more importantly, all of those vessels are deeply positioned within that double layer of peritoneum that we call mesentery. And in this case, quite literally, mesentery is the appropriate term. That's fascinating. So all of these variously colored structures you see here, to one degree or another, constitute peritoneum. This is the greater omentum down here. Remember, it's sort of a double fold of peritoneum that extends from the anterior wall of the stomach all the way down, folds back on itself, and then attaches to the transverse colon. But we have another omentum here with which you should be familiar with, and we'll break these down in a little more detail later, called the lesser omentum. And the lesser omentum we saw in that previous illustration is a double layer of peritoneum. It separates, half of which goes around the anterior stomach and half of which goes around the posterior stomach. But you can see it extends pretty much, for example, from the liver to the stomach. So a portion of this, for example, would be called the hepatogastric ligament. You'll have a full list of these in just a moment. But I just want you to see, and then of course, what is that? That's the tongue of the liver tongue, sticking its tongue out. That's the falciform ligament that we've already indicated again as the connection to the anterior abdominal wall. Very complex system. The green there is the mesentery. We've already described this. Very absolutely critical. It's extending to the individual small intestinal structures, the convolutions, not only supplying these with critical oxygenated arterial blood, but taking all of the food, all of the digesto, all of the nutrients that you've acquired from your 10-inch pizza, back to the liver through what's called the portal circulation we'll talk about later. So once again, parietal peritoneum, and then what do we call that double layer? The mesentery. And then that's going to surround the intestine that you see here, and then you can see a number of the retroperitoneal structures. So quite a complex system. We're sort of looking at it in a sagittal perspective here. Hopefully you can differentiate the parietal. You can see the mesenteric component here, transverse colon. So look at that greater momentum here, just because there are some other points that I want to make about this in another context. But here's the stomach. Here's that hepatogastric ligament. There's peritoneum, there's peritoneum. Then it falls forward, it falls anteriorly, it falls back on itself, and then reattaches to the transverse colon. You might be asking yourself, and I might want to do this experiment tonight, it might be worthwhile after all that you went through this morning. If you perform abdominal surgery, what would you have to contend with? Let's say you wanted to access the pancreas. How many peritoneal membranes would you have to traverse? And how would you get there? What would be your stratagem for attacking the pancreas? So all of these structures we looked at before, I just want to make sure you understand what we mean by a peritoneal ligament. A ligament in this context is just peritoneum that serves a binding function, mechanically binding function. Here it is on the anterior wall of the abdomen there. This is the gastrosplenic ligament there. Gastrosplenic ligament. But you can see that too is part of the peritoneal system. That greater omentum initially consisted of discrete or separate anterior and posterior layers, but as we age, they sort of weld or fuse together. So if you were to offer an opinion on this subject, how many layers are there in the greater omentum of the adult? 1, 2, 4. And you can see it's sometimes called the omental apron. Here's the stomach. This thing's draping down and then again folds back on itself and then reattaches to the transverse colon. Another illustration here. Often extremely fatty, and obese patients, it thickens along with the extraperitoneal fat and the extra-abdominal fat.
When we look at this picture, are we seeing the outermost layer and
Yep.
then it pulls back under?
Yep. And you would, if you do this tonight with a classmate, you'll be able to stick your fingers in here and just pull it right back. It's not attached. And what you will see, again, it's attachment to the transverse colon. By the way, another fancy word to add to your vocabulary, the gastrocolic ligament. Why is it called gastrocolic? The greater omentum, why is it called the gastrocolic ligament? From the stomach all the way down, it attaches to the transverse colon. And there you go. There is a reflected omentum. I wonder what they did with that fellow's omentum. I wonder what the surgery for the motorcycle accident. All right, so what we're looking at here, we've already talked about the greater omentum. So this is the greater omentum here. We said the largest component of that is the gastrocolic ligament. But if you pay attention, you'll notice that it extends all the way over here between the stomach and the spleen, forming the gastrosplenic ligament. There's also an attachment to the diaphragm we won't worry about, but I just want you to be familiar with the general, and you can sort of see the fold here, right? Folding back and then coming back on itself. Now the lesser omentum is going to be important for you as a PA because running through this portion of the lesser omentum is going to be the portal circulation. All the blood from the intestines going to the liver is right in here, and you can actually, because of the fold, you can actually reach back there and touch it. Clearly, you're going to have to find a classmate volunteer tonight. Well, we're going to come back to the portal vein. This is called the portal triad, and it includes the blood supply to the liver, the portal circulation, which we're going to have a different name for, and the bile ducts, all running there together. But before we get to that, again, the lesser omentum, just make sure you understand these fancy words, and understand their derivation. Hepatoduodenal would be over here. That's the one that I think is going to be important because that's the one that provides access to the portal triad. and the hepatogastric ligament. But both of these constitute the lesser omentum. We've used this term before. We talked about the bare area of the liver. The bare areas are simply those portions of a organ that are not in direct apposition to peritoneum. And you can see the bare area of the liver there. We talked about pleurisy, pleural inflammation, pleuritis. Likewise, there can be inflammation of the peritoneum. Oftentimes, that's associated with some type of infiltration of bacteria from the GI tract. But it could also result from external trauma as well. In or during inflammation, there may be points of attachment, points of adhesion between the visceral and parietal peritoneum. Sometimes those can be addressed surgically. Sometimes the individual may be born with these adhesions, and they can contribute to blockages, and that can be problematic. You've probably seen the children, malnourished children in various portions of the world with the enlarged bellies. You may have asked yourself, how could they both be simultaneously malnourished and have such large bellies? Well, what is that enlargement? What is the cause of that enlargement? Well, there's mass there being taken, there's volume being taken there by something. For the most part, it's inflammatory fluid. It's just basically water, and it can be drained. But that's ascites. That's at least a form of ascites. It's inflammation of the peritoneal cavity. All right, we were looking at this transection earlier, and I wanted you to be familiar, just wanted to introduce you to the complexity of this peritoneal system. Notice really what we have in the sagittal section are two compartments. There's the green and the red compartment. We're going to give that one name. And that's called the greater sac or the greater bursa. And so if you were performing some type of abdominal surgery, you probably access the greater sac initially. But again, I want to get back to the pancreas. I need to have somebody tell me how to get back to the pancreas. There it is. And notice, in order to access the pancreas, I'm going to have to go through the greater sac and then into this blue area here, which is called the lesser sac or the omental bursa. And you might want to look at the various possible pathways you might explore. Go that way, go this way. In any case, we talked about the lesser omentum, and there it is. And the portal triad is sitting right where that person's finger is, and that's called the omental or epiploic foramen. You remember fibular and perineal? There are two words to describe the same thing. Mm-hmm. Likewise, here, you should grow accustomed to saying these two terms. They're both used interchangeably, omental and epiploic. For example, these blood vessels right here are omental or epiploic. They're gastroepiploic or gastromental vessels. And there you see them. You see the portal triad accessed by means of the omental foramen. All right, any questions? That was the rough part. We got through that well enough. It's all down here, downhill from here. We won't take a lot of time to talk about the viscera. Some of this we have or will talk about in the physiology. We can make a few general points here. When we talk about the abdominal viscera, the contents of the abdominal cavity, you can see most of the important organs listed here. And we're also looking in the illustration on the lower right here at the blood supply to these tissues, and that's really where we're going to focus our attention initially, is the way that these structures are provided blood. Now, one simple way to do this that will help us for the remainder of our discussion is to look at this from an embryological perspective, and you can see that the old embryological terms include foregut, midgut, and hindgut. And so back here is our aorta. And at several points in the course already, we've made reference to the three major branches, abdominal branches from the aorta. We encounter these, for example, in our discussion of the autonomic nervous system. There is the celiac trunk, the superior mesenteric, and the inferior mesenteric. And so what do you notice about the relationship between those three vessels and the foregut, the midgut, and the hindgut? Yeah, the celiac supplies the foregut, the superior mesenteric supplies the midgut for the most part, and the inferior mesenteric more or less supplies the hindgut. Now, the point of division, or at least at the moment, between the foregut and the midgut is going to be about a third to halfway along the duodenum. And then the division between the midgut and the hindgut will be, and this is apparently highly variable because I've rarely seen two textbooks offer the same description, but this is going to be somewhere between 1/2 to the entire length of the transverse colon. So it could be anywhere from here back to here. And so everything distal to that, that would be the descending colon, the sigmoid colon, and the anal canal, and the rectum would all be supplied by the inferior mesenteric artery. So I think this is very useful to sort of use to organize your understanding of the blood supply to the viscera, especially the GI tract. We'll talk more about this in physiology, but I think for our purposes here, since I'm not sure how much time we'll have for the GI tract and the physiology, you should know that most digestion occurs in the proximal intestine. Do not be of the opinion that the stomach contributes significantly to digestion. It does not. Only about 20% of the protein, very little of anything else. Most of the digestion and uptake in the GI tract occurs in the proximal intestine, primarily the duodenum. That's in large part because of its proximity to the pancreas. The pancreas releases a variety of substances, including pancreatic enzymes and amylases and so on, that actually break down the food and render it assimilable by the epithelial cells that line the intestine. So we talked about these three arteries here. You have several illustrations showing these. Let's look at this one first. So be sure in an illustration like this that you can identify the celiac more credibly than I can draw a straight line. There's the celiac there. You see it right there? Cover it up and then I'll. And so the celiac, as a first approximation, gives rise to the hepatic arteries. They're shooting off this way. The gastric arteries, both the right and the left gastric arteries, and remember this word I used a moment ago, the gastro-omental artery. What's another way of expressing that? What's an alternate term for gastro-omental? Gastroepiploic. Gastroepiploic. And as Acklin would say, there it is. And then finally, the other major component of that celiac trunk or celiac artery is the splenic artery that you see running all the way back here to the spleen. And we'll talk a little bit more about these individual components, but I think that's pretty much what we want to focus on. And then just inferior to the celiac, right in here, where I'm drawing the big red blob, is the superior mesenteric. Again, just below the celiac. And we argued that the superior mesenteric is supplying everything, we don't see it here because they're not showing us the small intestine very thoroughly, everything from the duodenum, the distal duodenum, virtually the entire intestines, up to the transverse colon, that dividing line in the transverse colon we talked about. And then right there, again, if I were an ambitious person, I would change the color of my pen. But right there is the inferior mesenteric. Remember, the inferior mesenteric is supplying the, for our purposes, we'll say the descending colon, the sigmoid colon, and the anal canal. So very easy. Any questions about the blood supply? We're looking at a cadaver preparation. So here's the aorta. See the little arms there? Those are the arms of the renal. The aorta is descending through, we can see it here, the aortic, I'm sorry, that is the aortic hiatus, the aortic hiatus. This is the diaphragm here. And so the diaphragm rather wraps around the aorta. Here's the cable hiatus over there. It's actually a little superior, but that's the internal vein. The vena cava emerging from the liver. And then here's our celiac artery, superior mesenteric, inferior mesenteric. Of course, this is where the aorta branches into the iliac, common iliac. Now, the return, the venous system is a little bit less straightforward. So you can see we have a large central structure here, central stalk. It has a couple of names, at least. And then there's this region, there's this large structure going over to the spleen. And then finally, there's this third structure descending from the splenic vein. All right? So maybe that's the easiest one to start with. This is the inferior mesenteric vein here. And in most of your patients and most individuals, it sprouts proximally from the splenic vein, this being the splenic vein. When you do your Ackland analysis, you're going to find that the specimen he uses looks nothing like this. So you should anticipate, as with many other structures, considerable variability. Sometimes that inferior mesenteric comes off right here, and sometimes it actually comes off this structure, which is the superior mesenteric vein. So the superior mesenteric vein is that structure inferior to the splenic. The blood's all going superiorly. Blood's all moving in this direction. And it's all emptying into this large structure right here called the portal vein. And what is that back there? That's the vena cava. So somewhere within the matrix of that liver, this has to end up in here. And we'll talk about that later. Any questions, though, about the venous, the large veins? A little bit tricky, and again, don't always anticipate that they'll go quite this way. Otherwise, the extent of drainage is comparable to that of the arteries we just talked about. Inferior mesenteric vein, pretty much descending colon, sigmoid. Superior mesenteric vein drains the intestine up to the distal duodenum, and then the celiac. I'm sorry, the portal. Actually, that's a good point. As you can see, I'm getting tired here. But the gastric, all of these blood vessels in here can drain variously, either into the splenic vein, sometimes directly into the portal vein. You can see, for example, the gastroepiploic vein draining into the superior mesenteric and the gastric veins draining into the portal. So there's diverse drainage up there in the region of the duodenum and the stomach. We've already talked about the esophagus. I think anatomically what I would have you recognize in an image like this, make sure you note that the esophagus descends with a convex curvature toward the posterior wall. It's adjacent to the spinal column at that point. Remember, it sort of flexes anteriorly, superiorly, and then flexes both anteriorly and to the left inferiorly. And so we now have talked about 3 openings through the diaphragm. What are the 3 openings through the diaphragm we mentioned? The 3 hiatuses, which is all, I'm sure you're all craving a hiatus right now. Not going to happen. If I suffer, you've got to suffer. Some of you are begging for mercy, but you think I'm going to not see you falling asleep. But I don't care. I can fall asleep too. I'm asleep right now. What are the 3 hiatuses? Esophageal, aortic, and cable. Yeah. So hopefully we'll have time to look at these. But at this point, I want you to be sure you can see. And you can see the esophageal hiatus there. All right, let's come back. Let's take a break, and we'll come back and talk about the stomach. Let's take a 15 minute break. Actually, we're through on this, so we'll come back with physiology.